Hi, this is Dr. Bob Dannenhoffer, the Public Health Officer for Douglas County, with another of our Facebook Live updates, this time during Christmas week. I'm here in the studio all by myself, so I am going to take down my mask so those of you who read lips can see what I'm saying. Again, this is your chance to ask questions. You can do the questions either at our email at facebookquestions@douglaspublichealthnetwork.org, or you can put them in the chat and we'll pick them up as we go on. Again, your chance to ask questions and my chance to give as best as I can do. So in the world, still a very active pandemic. We continue adding cases at a faster rate than ever before. There's now 77 million cases, 1.7 million deaths. We're adding about 700,000 cases every day. Think back to when China had it. They had 80,000 cases total in their first wave of it, and now we're adding 700,000 cases every day. And the deaths are piling up. We're adding about 10,000 deaths per day. In the world, still very hot in the US, Brazil, Russia, UK, and Turkey. All of those countries, US, Brazil, Russia, UK, and Turkey, are all going up. Also active, though, in Germany, France, and Italy, but those are starting to go down. We're also seeing in the world some small countries in Europe, such as the Czech Republic, really struggling with the disease, and especially Sweden. So you remember Sweden has been one of the ones we've been looking at because Sweden took a different approach from Norway and Finland, their sense being that you could build up herd immunity, and while they may struggle early on, they would do better later on. Well, now it's later on, and remember Sweden is about the same size as Norway and Finland combined in terms of population, and Sweden still has 10 times as many cases every day as Norway and Finland. So that has not really worked for them to keep cases down. U.S. is still far and away the most number of cases, so U.S. has more cases than Brazil, Russia, UK, Turkey, Germany, France, and Italy combined on a daily basis. So really struggling in the U.S. with number of cases. At the U.S., we're over 18 million cases and over 325,000 deaths. When I look at the daily amounts, it looks like we may be flattening at a little over 200,000 cases a day. While it's good that we're flattening, 200,000 cases a day is an astonishing number of cases. Remember, our case fatality rate is likely to be about 1 or 2%. So that means we're going to have over 2,000 deaths a day for the next month. That is really concerning. Deaths are rising. Now we're averaging 2,200 deaths a day. And when you look at the daily numbers, they're now very erratic. Early on, they were not quite so erratic, but now they're very erratic because there are many places that are only reporting a few times a week. There are many places that are not reporting on the weekends. So you see this huge jump day to day. I really don't think there's that much jump day to day. I just think some of it is the reporting delay. And we've seen a little bit of that in Oregon. Well, the number which has the least variability in it is the hospitalization number. The hospitalization number is reported by the hospitals every day. They work every day, so there's very little lag and there's very little underreporting. And when you look at that curve, it's nice and smooth. But today there are 117,000 people in hospital with COVID. Now, you say, well, there's lots of hospital beds, but there aren't that many. There's about 900,000 total hospital beds, some of which are not really staffed. So, for example, the small hospitals on the coast have capacity for maybe 10 or 20 beds, but they typically are very much smaller. So this 117,000 people in the hospitals with COVID is really straining the hospital system. Now, again, not so much in Oregon, and certainly not in Douglas County, but certainly struggling in other places in the country. In Oregon, we are doing better. We're a little over 100,000 cases and 1,300 deaths. I believe our case peaked in early December. The hospitalizations peaked last week, and the deaths are peaking now. When we look at our reproductive number, that's how fast the cases are multiplying. When the number's over 1, it means the cases are increasing. When the number's under 1, it means the cases are decreasing. Oregon's RT is now under 1. And when we look at Oregon, it's the 4th lowest state. So except for Vermont, which has done a very good job, Maine, which has done a good job, Hawaii and Oregon, we're the 4 lowest states and far and away the biggest of those 4 states. Douglas County, we're at a little over 1,300 cases, 36 deaths. We are, when we look at all of the counties in the country, for counties that are over 100,000, I think we are the lowest county. You may be able to find one other county. Honolulu County is a bigger county with a low rate, but pretty much for when you get counties over 100,000, we're the lowest in the entire country. That's stunning. And when we look at our case rate, we are the third lowest in Oregon. So the only counties that are lower than us are Gillum and Wallowa. And so now we've dropped under the 200 per 100,000. And I believe we're going to move from extreme risk, which is where most of the counties in Oregon are, down to high risk. And that would be a great thing. PPE is still tight. So we wouldn't think that 9 months into this we'd be struggling still with PPE. But still, PPE like masks and gowns are continually short, and they're hard to get. So it's not just that hospitals don't have them, nursing homes don't have them. It's that nursing homes and hospitals try to buy them, and they say, sure, we'll deliver a bunch next week, and then they never come. Or when you buy them, they're much more expensive than they were before. So masks, even then, this is not an N95, this is just a regular surgical mask, used to be like a penny or two, now they're 15 cents. When you look at the N95 masks, they used to be 10 cents, now they're $1. So not only are these things harder to get, but they're much more expensive than they were before. We're still doing lots of testing. We did some testing today. We still have lots of Binex testing, so it should be easy to get a test. We brought them out to 30 different clinics in the area. Again, these tests are best in people who are symptomatic. So if you're symptomatic, it's far more likely to be accurate than when you're asymptomatic. So we're certainly suggesting that anybody who's symptomatic should get tested. And there's lots to do about the vaccine. So the vaccine is a big deal, and I'm sure we'll get questions about that today. One of the things we've been doing, we've been following other counties. So since August, we've been following 4 counties in the U.S. that have similar populations, similar demographics, similarly on the freeway and such. And we look to see how they do. So Douglas County, about 1,300 cases and 36 deaths, about 10 cases a day. So 1,300 cases, 36 deaths, 10 cases a day. Twin Falls in Idaho, 7,600 cases, about 6 times as many cases, 111 deaths, 3 times as many deaths, and 37 cases a day. Again, 3 times as many cases. Pennington County in South Dakota. Now, somebody sent me a message last week that they thought we should be more like South Dakota. Okay, so Pennington County with Rapid City in it is similar to Douglas County. It's younger, so it actually should be doing better than Douglas County. Slightly higher income. Again, we've had 1,200 cases. They've had 10,543 cases. We've had 36 deaths. They've had 122 deaths. And while we are averaging 10 cases a day, they're averaging 63 cases a day. So again, yes, we could have like Rapid City. That is not something as a public health person that I would want. And Lowndes County is between the two. Okay, so I talked last week about mutations. I'm sure we're going to talk more about mutations. So Sandy says, what happens if we get the first shot of the vaccine and then there's not enough for the second vaccine? Great question, and we plan for that. So what's happening is every time vaccine is given into a place, an equal amount of the vaccine is held back to get the second dose. And so it is well planned that that everybody who wants the second dose can get it. Now in the studies that they did on the vaccine, almost everybody got the second dose. We think in real life it's probably not going to be 100% getting the second dose. There are going to be some people decide the first time they didn't like the side effects, or they've heard something new, or they move and they won't get the second dose. But yes, we're working on that. So if somebody had COVID in November and recovered, can they still spread COVID? We do not think so. So the best way to know this is by doing studies called viral cultures, looking for actual virus that can grow. And we think that if you are not immunocompromised and not so sick to be in the hospital, that after 10 days, you're not going to be spreading this. So we do not have long-term spread of this virus. That's a good thing. That's about the only good thing about this virus I can think about. So why isn't more effort being put into mass production of the Moderna vaccine, given that it's easy to store and distribute? Casey asked. I think Moderna is working full-time on this. Now, I'll tell you, Moderna does not put out vaccines before. So it's not like one of the other big companies that has plants in 7 places around the country. Moderna is just a startup company from Cambridge, Massachusetts. And so they've not been in the business of putting a vaccine out. And that's one of the risks here, is that Moderna does not have a lot of it. In fact, they don't even make their own vaccine. They use it, they source it from places around the world, and it comes together to make the vaccine. That's pretty dangerous. There's lots of little parts there, and this vaccine is dependent upon every part, be it the glass, be it the paper on the label, be it the stoppers, be it the little things that go together, be it the quality control mechanisms. And so this is a somewhat flimsy platform for us to be so dependent upon, but it is what it is. So Jackie says, is it true that there's a new strain that's 70 times more contagious? So this is where mutations come in. So when we talked on Friday, I did my reviews around noontime, and then I had work to do. And it turned out that between noon and the time we started at 4 o'clock, there was breaking news about this new mutation in the UK. So as we had talked last time, there's lots of mutations of this virus. Viruses mutate. This one mutates less than some viruses because it has a proofreading mechanism, but it still mutates. And it especially mutates when it's spreading rapidly in populations. And we worry that it also mutates rapidly when it's spreaded in big populations of people who don't get very sick, or mink that don't get very sick. So you remember a month ago we talked about this spreading in mink farms. And that was our big concern about spread in mink farms. I mean, if the mink died, that would be a tragedy, but would be a greater tragedy is that the mink would spread this disease among themselves. They wouldn't be terribly ill, but that there would be now mutations of this virus that they would then give to the keepers, and then the keepers would give it to others. So we do not know where this new mutant came from. It might have come from mink, might have come elsewhere, but this new mutant, which is called the B.1.1.7, does seem to be more contagious, not 70 times, maybe I've heard 30 to 40% more contagious. So I don't know where the 70 times more contagious, that would be a lot. If it was 70 times more contagious, we're in for a really rough ride. It's likely to be more contagious, but not that much more contagious. And more contagious is problematic. And it's more because it'll spread quicker before everybody gets the vaccine, and will require a higher percent of the people to become immunized. So the way you figure this out, how many people need to get immunized, is you take the number 1, and then you subtract 1 over the number of average people it spreads to. So this one is 1 minus 1 over 3. So 1 minus a third is 2/3. And that's where you've been hearing the 2/3. However, if this now has an R of 6, say, because of this new mutation, it's going to be 1 minus 1 over 6, which is 1/6, which is 5/6, which is a much higher number, close to what the vaccine efficacy is, meaning that almost everybody's going to need to get vaccinated, a much more complicated issue. The other concern we have with this is that this mutation is a bunch of mutations, not just one mutation. It's a bunch of little mutations, including deletions, changes of amino acids. We're not sure what all of those do, but there's some suggestion it may make it more virulent in young people. There's some suggestion that it could change the surface protein so that the antibodies that you make from the vaccine will adhere less rigidly. And so this is a big concern, and we're going to be following this carefully. We do not know how much more contagious it is. I saw estimates today that anywhere from 30% more contagious to twice as contagious. I didn't see the 70 times. And whether it's going to be the vaccine is going to be effective, we do not know. So Cheryl says, can you post the flu death data versus the COVID, and talks about people being resistant to hearing this. Yeah, so what happens is flu deaths are calculated in a different way. Flu deaths are calculated kind of in retrospect as being the number of excess deaths seen in an area. If we did that, the COVID deaths would even be higher than they are now. We will post any deaths that are related to the flu like they are related to COVID. So far in Oregon, there are 0. The one time that we do this is with children. So far, there are 0 flu deaths. And so this disease is many, many times worse than the flu. We think 20 times worse than the flu. So Niall says, is the federal response satisfactory? Yeah. So I really, as you noticed, have tried to stay away from politics, and I'll try and stay away from politics now. When this is all over, I've written this all out. We can talk about it. I think there are a bunch of things that have happened in the federal response that have been excellent. I think our move to get the vaccine has been great. I think the idea that the feds would take the financial risk so that the companies wouldn't have to worry about the financial risk and they could move ahead with the vaccine has been great. I think our Surgeon General is a great spokesperson and really a lovely person too. So I think our Surgeon General has done a great job. I think Dr. Fauci has done a great job. I think the rest of the coronavirus task force has done a pretty good job of what goes on. And as my mother said, and I hope she's watching, you can't say something nice, don't say anything else. And other than that, I think the federal response has been really problematic. So, so Tamara says about the ivermectin. I tried to find the Pierre Corey thing, and I couldn't find specifically what you were talking about, Tamara, but I'll look again. So ivermectin is a drug, been around for a long time. We use it to treat parasites. My dog is taking it to prevent heartworm. And so ivermectin has been around a long time. And ivermectin is an anti-parasitic drug, but has sort of other funny factors. And it's one of the drugs that has been studied to treat COVID. And some initial data that is there, and it's really intriguing that it could work. The other drug that's there where there's some intriguing data is a drug called Luvox, which is a drug which is used to treat obsessive compulsive disorder. And both of these drugs look like they could have some efficacy. But as we said last time, and I'll say again and again, having been in this business a long time, as my kids say, since the last millennium, since I've been in this business a long time, every year there's a bunch of exciting things that come out to treat cancer, to treat autism, the cause of SIDS and all of that. And about 2 out of 10, 1 out of 10 play out to be real. Many of the things that are out there like, this must be the cause of this disease, comes out 3 months later to say, not really. So again, ivermectin is a good observational thing. Luvox is both observational and there's a controlled study. So Luvox is a little further ahead. But again, there's 4 or 5 of these out there. Ivermectin is there. Looks like it's the Pepcid, that medicine that you use to treat heartburn. Actually, there was some really fascinating data in April and May that suggested that in China, people who took Pepcid for their heartburn did better than people who took proton pump inhibitors, like the more expensive drugs. And so it was like, my goodness, you should go ahead and everybody take Pepcid. Well, they've worked on it and they can't show that same difference. Certainly with ivermectin, I would really hope that somebody would do a study, and it would not take a lot to do the study. For example, the study on Luvox was a really interesting study. They saw observationally from France that people who were on a class of antidepressants had lower rates of bad disease than people who weren't. And they said, well, maybe this has to do with what's called the sigma-1 receptor. So they found the strongest sigma-1 receptor drug, which is Luvox. And they and for people who were diagnosed, they give them a bag that had a thermometer and a pulse ox and said, if you want to be part of the study, take the pills that are in this bag. Some had Luvox and some had placebo. And in the end, they looked to see what happened. And in fact, Luvox seemed really to work. None of the people on the Luvox side got worse, and the expected number on the placebo side got worse. So Luvox really looked like it worked. You could really do the same with ivermectin. There are so many cases in this country that it would not take very long to come up with the 200 or 300 people you would need to study that. So my answer on this is, please, let's see a convincing study, and this would be great. So Tracy said, what is the vaccine stability after reconstitution, hours or days? Again, it depends. The difference between the Pfizer vaccine, which is less than a day, or the Moderna vaccine, which is considerably longer. So the Pfizer vaccine is really, really finicky. And so the Pfizer vaccine needs to be taken out of the deep freeze, defrosted, and given. Not a lot of leeway there. The Moderna can stay in the refrigerator for 30 days. So we think the Pfizer vaccine is going to work best at places like hospitals and university dispensaries, whereas the Moderna vaccine is going to be what's going to be at most clinics, fire stations, and smaller hospitals. So Debbie says, I know that face coverings can reduce transmission, but is also protecting the wearer. So studies to show that it's protecting the wearer are really hard to do, because it's really hard to do a double-blind study because you know who's wearing masks and not. There was a study done over in Europe called the Dan mask study, and what it showed is that there was a slight protection for the wearer. However, it was really a troubled study because the people who were in the mask-wearing group were not very good at wearing the masks, and many of the people who were not in the mask-wearing group wore the masks just because they heard about it on TV or something. And so rather than having 100% in the mask group and 0% in the other group, it was maybe more like 20-60. And so it was a little hard to tell, but even that one showed a small difference. So I think they do protect the wearer, especially if you use a good quality mask, but clearly they protect others. So Kathleen says, I received an email from Fred Myers about an antibody test. Is that legit? Well, I don't know about this one in particular, but there are lots of antibody tests out there. And the antibody test can tell if you've had the disease. Now, the hope is that you could find the antibodies early enough that you could tell if you have the disease. So far, that hasn't really played out yet. But yes, there are many antibody tests out there. When the antibody test first came out, it was sort of an open field. They let a lot of people make antibody tests, many of which were crap. The crap ones have gotten pushed off the market. Pretty much the ones from the big labs that are out there now are really quite good. And if you want to get an antibody test, that would be great. So why do the Douglas County cases not show up on the Johns Hopkins case map? I follow 4 maps: the CDC map, the Worldometer map, the COVID Act Now map, and the other one, the COVID. There's another one I follow. I don't follow the Johns Hopkins. I find it complicated and super dark, so I don't look at that. I don't know why the cases don't show up. I would recommend, if anybody wants to see the cases, look at the New York Times map. The New York Times map is beautiful. It's big, it's beautiful. You can spread it with your fingers, and you can look and see. It's kept up to date to the day, so that's the one I use. Yeah, so is there any facility in Oregon that's able to do the IV antibody treatment for those who have COVID but aren't in the hospital? So this is the other thing that's out there, is this antibody treatment. So the IV antibody treatment was originally designed for use in nursing homes. And the thought was that you'd have a nursing home, there'd be an outbreak, somebody would have it, they'd go to a special COVID place in the nursing home, and because they're in nursing care and a really high risk for getting in the hospital, you'd give them a dose of the IV antibody and things would work. Well, it hasn't worked that way. Unfortunately, this got politicized after Giuliani got it and Carson got it and the president got it. And so now it's a free-for-all on this drug. We don't know how well it's going to work. It doesn't seem to change mortality much, although it does change hospitalization, which for nursing homes is going to be a big deal. And so it's kind of a mess. The only place that I know that's doing is down in Ashland. They're only doing a few places a day. We tried to get it started here in Douglas County, but it's been really hard to get it started because a couple things happen. One is you gotta get it. You gotta be in the right group. That is, people at risk for progression who have not yet progressed and early in the disease. And then you're sick, right? Because you got the disease and you're contagious. You need to get a ride, maybe expose other people. You go to a clinic where you're going to expose other people. So it's really very, very complicated to do on an outpatient basis, and I think this is why it hasn't worked. There was a story at NPR this morning that talked about this, that other places are really set up and they don't have very many takers. Again, this would be far and away the best for nursing homes. Again, you'd already be there. You wouldn't be exposing anybody new. You'd already be in a nursing situation where they know how to do IVs and whatever else, and you have a really high risk for progression. So that, I'm probably don't have super high risk for progression at my age, but the way it is now, I could get it. A 21-year-old who was positive and rich enough to have a doctor come to their house could get it. And so there's all kinds of concerns about this. And when somebody talked about the federal effort before, I'm winking. So will volunteers and students working in daycares be considered with educators for vaccines? That decision is being made this week, and I do not think it's been announced yet. But I think the goal, though, is that daycares, preschools, schools are kind of vital to society to have people go there so other people can safely go to work. So I think they're going to be considered relatively high. The problem, unfortunately, is everybody thinks they should be high. So healthcare workers are sort of that first group that you can kind of define that, and people in nursing homes, you can kind of define that. But once you start to get to the 1B group with essential workers, or wood products workers, essential workers, yes, by one definition. Are the people who work at the fast food restaurants? Yes, by one definition. Are people who drive long-haul trucks, although they presumably don't have a lot of exposure, are they high risk? Yes. And so there's a lot of people angling to be in that high-risk group. Well, if everybody's in the high-risk group, then there's so many people in the high-risk group that it gets slow. And what we're hoping for is that we don't have a mob scene with people trying to climb over each other. So Jerry says, do I think the Moderna vaccine is safe? Yes. They're supposed to get it tomorrow. Great. I hope I'm going to get it the next week or two. So yes, I think the Moderna vaccine looks good. There are some local side effects, so I think people should be aware that if they wake up the next morning and go, oh my God, my arm feels terrible and I'm not feeling that great today, that you won't be surprised. It means the vaccine is working. And so I think it's safe, and I would get it tomorrow if it was there. Yeah, so Lori says, after having had a reaction to penicillin a few years ago, should I be given the vaccine for COVID? Lori asked, and the reason this is a concern is there have been now a handful of anaphylactic and anaphylactoid. So anaphylactic means the full-blown thing, and anaphylactoid meaning you have some of the symptoms of anaphylaxis. Anaphylaxis is freaking scary to watch, right? So somebody takes something, their face swells up, they start to get hives over, they have trouble breathing, their blood pressure goes down. You have to give them epinephrine and Benadryl. I mean, it's sort of a complicated deal, and so people worry about it. And most of the people who've had this reaction have a previous allergic reaction, although not all. There's some people who've not had a previous allergic reaction who've had a reaction to this vaccine. So the recommendation is talk to your doctor. Now, I kind of hate that because they always say, well, talk with your doctor. Well, sometimes your doctor doesn't know anything more than anybody else, right? Dr. Fauci doesn't know whether you should get it or not. Certainly your doctor doesn't know as much about this vaccine as he or others. I think for people who have a previous allergic reaction, I think they can get it. I think you want to be in a place that's set up to take care of an allergic reaction. Again, 99.9% of the people who have allergic reactions did not have an allergic reaction after this. However, if you're the 1 in 1,000, you want to be sure you're at a place where they can do resuscitation. Yeah, so Stacy says, how long after being recovered from COVID should a person get the vaccine? This has changed. Originally, they thought 90 days, and there was something yesterday that said there should be a time frame. So I do not know the answer. I don't know where they're going to set upon. Now, if you've just had COVID, you're very unlikely to get it in the next little bit. And what you may do is stand back in line and let somebody else who doesn't have antibodies get it first, and then 90 days after your disease, hopefully there'll be much more vaccine there, and you won't be displacing somebody else. Yeah, so Janet says, since bars and restaurants are putting up closed tents for outdoor seating, why don't they just open up the restaurant? Seems bad to possibly spread the virus just like inside. Yeah, so the thought was that outdoor dining would be truly outdoors, where there'd be the breeze wafting by and tremendously decreasing your risk. I've seen now some of these seating things that are like these enclosed airtight pods. Well, once you get an enclosed airtight pod, there's really no different from being inside. Again, with tents, you'd like to have some opening so that you may not get rained on, but there would be some opening along the way. The definition of outdoor seating is open on 3 sides, although I'm not sure anybody is specifically counting. There's a thing about antiviral cloth with Active. I'll have to look that up because I don't know what Active is. So Ralph says, will the revised CDC guidelines for prioritizing vaccine recipients change Oregon's stated plans and the timeline for distribution? I don't know. As I said, I was on a call earlier today, and they don't see this before you see this in the news. And so they were struggling a little bit to see if they could harmonize those. And what they did is now the CDC added to people over 75 to the group of essential workers. So 1B, which used to be kind of small, truly essential workers, is truly essential workers, people over 75, wood products, all those others. So 1B is getting bigger and bigger and bigger and bigger. And the problem, unfortunately, is that as 1B gets bigger and bigger and bigger, then it's later until you get to the 1C group, which are people over 65 and less than 75, people with high-risk conditions, and that's a high-risk group. And so we're sorting our way through this. One of the biggest concerns is this guidance changes every single day. So I spend hours a day going through this stuff, think I got it, and then the next day it has changed. We talked today with Pat Allen about the vaccine distributions. They have a list that has numbers on it. You think, oh, I got this here. The next day it comes out and it's different. And so any predictions on this is really hard. So some people want us to plan vaccine events, and I certainly want to do this, but somebody made the really astute observation. This is sort of like planning a wedding, but you don't know what day who's getting married, but you don't know what day it's going to be, what the wedding list is going to be, where it's going to be, or what the venue is going to be. Just be happy about planning it. Well, anybody who's planning a big event like that, you want to have these things months in advance so you get there. So I have no clue about where I'm going to get the vaccine. On Friday, we said that the public health authorities may not get the vaccine until February. And then I was on a call at noon and they said you could get some next week. So, that kind of thing makes it really hard for me to plan. And I don't know what the answer is about when we're going to get it or what we're going to do. What I do know is that if anybody's going to be ready, we're going to be ready. We have done these vaccine things before, so we know what to do. We've already contacted the people who are going to do what are called the points of dispensation or pods for this first round. We're getting people signed up. We're getting people all the stuff that they need to do this. And it's a considerable amount of stuff to get ready to do this. So we're going to be the first. But, when you can tell me on Friday, oh, you won't get it till February, and then you tell me today you might get it next week, you can imagine how hard that is to plan, right? Like the wedding, well, it's going to be in February. You can kind of plan that and say, oh no, it's going to be next week. That would give some heartburn. Yeah, Amanda says I'm allergic to penicillin, amoxicillin, and several other antibiotics. Which is the best vaccine for me? Well, both of the ones so far have no antibiotics in them, and so or no preservatives in them because they're so cold, and so I don't think you have to worry about that. Depending on what your allergic reaction is. If your allergic reaction was a non-anaphylactic reaction, I don't think it makes a difference. If you did have an anaphylactic reaction, that is, you had hives and shortness of breath and whatever else, then I think you want to be careful to do it at a place where, they are ready to treat an anaphylactic reaction. So Amanda says, how accurate are the rapid tests? I had one after 5 days of symptoms and then got one. It came up negative. Should I worry? So Amanda, if you could make the question a little clearer, I will get back to you. And Vanessa, if you could help me with that. So should people with autoimmune disease such as scleroderma or lupus get the vaccine? So in the vaccine trials, people with underlying immune diseases got the vaccine, and when they did a subgroup analysis, it did not seem that they had any better or worse time with it, or better or worse protection. So it looks like the answer should be yes, that if you have an underlying disease like lupus or scleroderma or something like that, you should get the vaccine. In fact, there were no underlying conditions which seemed to make this vaccine a no-go. So Kat says, well, does it make sense to do a quick test before giving the vaccine? There's no recommendations to do that. Would it make sense? I'm trying to think. No. I mean, the chance that you'll have a positive, if you're asymptomatic, the chance that you have a positive test in Douglas County is less than 1 in 1,000. So I'm not sure it makes sense to give 1,000 tests to find the one person who's pre-symptomatic, because I don't think it makes a difference. Will the vaccine work if you are pre-symptomatic? It should. There's no reason it shouldn't work, and there's no reason it should change the course of your disease. So I'm not sure that it would make sense to do a quick test. Yeah, Connie says, why does it seem like Oregon is getting less and less vaccines? Is this true? Well, the initial predictions were far and away the rosiest thing I'd ever seen. I mean, it was like, it's assuming that everything went perfectly and there would be no roadblocks in the way. And anybody who's done any kind of complicated planning realizes that you plan and want to perform and hopefully want to under-promise and over-perform. In this case, they promised the moon and there were problems. So for example, on the Pfizer vaccine, they forgot to put in there that, oh, that's right, once the Pfizer vaccine is produced, it needs to go through quality control lots. I mean, not surprisingly, and that takes some time, and so they wouldn't be immediately available. And so what we've seen is really, really, really rosy predictions, and these rosy predictions sadly have not come true. I mean, we've been dealing with this from the beginning. I cannot tell you the number of months we said, we'll have 1 million tests by the end of the week, and then the week came and went, and it wasn't there. 2 weeks later, we're going to have 1 million tests by the end of the week. We came and went, and we never had it. So there's a lot of over-promising there. And it does seem like we're getting less and less vaccine. Then on the other hand, then vaccine shows up and you don't know where it's coming from. Again, I think somewhere between next week and February, the Public Health Authority will have some vaccine to distribute. So what group do at-home caregivers for 75-year plus fall into? I don't know. And again, this is one of the things that got changed today when MMWR changed the 1B guidance, and Oregon hasn't finalized that yet, so I do not know. It is going to, I don't know if they're going to fit in 1A or 1B. Samantha says, do I think international travel will at least be somewhat more open by the summer? So, people always want to know, about predictions. And there was this old baseball guy said, predictions are really hard, especially about the future. And so that's just what the problem is. By next summer, there could be so much changing. I mean, I think 6 months ago, how hard it would have predicted where we are now is, I think, going to be similarly hard. My best case scenario is that this new mutation is interesting but not important, that the vaccines work as we think, that we get 2 new vaccines by February or March, so that now we have 4 vaccines and 700 million doses available in the U.S., and that we rise to the challenge of immunizing people, and that by the summertime we have 300 million people in the U.S. vaccinated and 300 million people in Europe and a similar percentage in Europe vaccinated, in which case travel would be much more open. I think that is the best case scenario, that by the beginning of summer, everybody's going to be immune. I think a more reasonable one is that by the end of the summer, we'll get to there. And I think, looking at people who don't want to get the vaccine, looking at the fact that every time we have vaccine stuff, it's always a little lower and a little later. It may not be until next fall where we're there. So will the VA prioritize recipients of the vaccine by age? Again, I do not know how the VA is doing it. What I do know is the VA is starting out on their healthcare workers, and a good friend of mine, and one of the loveliest people you'll ever meet, is actually doing those vaccines. So I do not know how they're going to do their patients. I know they're going to do staff first. So Amanda comes back. She had a rapid test after 5 days of symptoms, was negative. Now she's on the 10th day and still sick. Should they get retested? Yes. So, there's always a possibility that those rapid tests are not going to be accurate. We found they're about, for people who are symptomatic, they're 80 or 90% accurate, which means that 4 times out of 5 is going to give you the correct answer, but 1 time out of 5 it will not. So if you're 10 days and still sick, yes, you should get tested again. If it's still negative, then it's likely you're negative. But still, regardless of what goes on, you should not go back to work or school until your symptoms have resolved. Yeah, so what if you had 3 different severe reactions to biologic drugs used for the treatment of RA? One caused sarcoidosis. Would you still get the vaccine? Well, so here's the good news. What we currently think now is that about 60 to 70% of the people need to be immune. Not 100%, 60 to 70%. And I think with your kind of thing, if you would say, look, how about if you do this for me? That's great. So people have noticed during the time here, I give blood all the time. And not everybody can give blood. Some people have terrible veins. Some people have had a travel thing. They have some other reason that they can't give blood. Everybody doesn't need to give blood, but a bunch of us do, so there'll be enough blood in the supply. And I have no contraindications and my veins are good, so I give blood every time. But I know there are a lot of people who can't. Similarly with this, there are going to be some people, you have kind of a complicated history, and I'd certainly talk with your doctor about that. But I think people would certainly understand if you would decide to be later in the thing. But the young, healthy among us should be the first to do it. So one of the things I've said along the way is about should breastfeeding moms get the vaccine. Well, this was not tested in breastfeeding moms, so we're not sure it's going to be safe. We think it is, but we're not sure it is. There aren't that many breastfeeding moms out there. My daughter-in-law is breastfeeding, just had a baby. And so what I would say is, everybody else around her who's not breastfeeding, obviously, should get the vaccine so that she doesn't need to. Similarly, if everybody around you, Linda, gets the vaccine, then you don't need to. We do this with other vaccines. I've got 2 kids that have heart transplants. Kids with heart transplants, there are not very many of them in the country, and I have 2 that I take care of. And both of these kids, lovely kids and lovely families, they cannot get a measles vaccine. Well, they don't really need to get a measles vaccine if everybody around them is immune to the measles, because if everybody around them is immune to the measles, then they will never come in contact with measles. And that's why it's important that people who say, well, I'd rather not get the measles vaccine, get it, unless you absolutely can't, like these 2. And similarly, we clearly do not need to have everybody be vaccinated. So talk to your doctor about that. So Tamara says, would I agree that if a person's immune system is healthy and strong, that they're more able to fight off COVID? So we clearly know that people who are healthier are more likely to fight off COVID. So clearly young, healthy people who are athletes and whatever, far more likely to fight off this disease than people who are old and sick. Certainly people who are healthy and trim are much more likely to fight off this disease than people who are obese. People who are smokers, much less likely to fight off the disease than people who are exercising and not smoking. The problem is that there is no particularly good measure of one's immune system, right? So you can measure my cardiovascular system. You put a echocardiogram and you can see what my ejection fraction is. And people with good high ejection fractions, you've got strong heart. Similarly, for my kidney function, you can measure my blood creatinine. If my blood creatinine is low and my blood pressure is good, there's no protein in my urine, then I've got good, strong kidneys. Whereas if your creatinine is high, your blood pressure is high, there's blood in your pee, you likely don't have as good kidney function. So there's good measure of heart function, there's good measures of kidney function, there's even reasonably good measures of brain function. But there's not a particularly good measure of immune function. So when I test somebody's immunity, I can measure their level of antibodies. I can measure how many T cells they have. I can see what kind of reactions they have to skin tests. And those are kind of measures of the immune system, but they really only point out people who have weakened immune systems. So they can only point out for example, people with HIV have a weakened immune system, or people born with no antibodies who have something called agamma-globulinemia, they can point that out. Or if I have no reaction to a Candida skin test, it means my T cell immunity is probably decreased. But it doesn't really. But if you're positive on all those tests, which about 95% of people are going to have normal results on those tests, it doesn't grade the person who's got the lowest immunity and the highest immunity. And that has been one of the huge problems in healthcare. People say about building your immune system, and we don't have a particularly good way to measure that. And so that is actually one of the things that we would hope that would come out of this. We obviously did a lot of blood work on people who were there, and hopefully we'll be able to find markers in the blood or some other way to determine who had the best immune system. So Tamara, I would think that people have healthy immune systems are more likely to fight off, but right now I don't have a good way to measure that. We do know that farmers' kids tend to do best with most immune things. So we call this the hygiene hypothesis. So kids who sleep in the barn and clean up after the dog and whatever do seem to be healthier than kids who live in relatively sterile environments. But again, when you try to measure that by using the standard ways we measure the immune system, really can't do that. So Tamara, I would agree that people who are healthy and strong are most likely to do this. But if you know of a better way to really measure the immune function, I'd love to see that. So Karen says they're 70 years old and being treated for bone cancer. What group for vaccines would I be in? I believe you would be in 1C. That's 65 to 75 with underlying conditions. Janice says, do I recommend that employers require employees get vaccinated? Well, this is a story for sometime later. Right now, there are far more people who want vaccines than there are vaccines available. And so my goal at this point would be to get the vaccines to the willing. At some point later, let's say we get to May or June, and I said by then we hope to get more people vaccinated. And at that point, let's say only 30% of the people wanted the vaccine, and only now 15 or 18% of the people, 22%, something like that, are immune, and we're still seeing the disease spread because there's not enough. Then I think we have to have a national discussion what we do about people who don't want to get the vaccine. My sense is people are going to see that this vaccine works, people are going to see that this vaccine is safe, and I think we're going to get 70 or 80% of people want the vaccine, in which case requiring the vaccine will not be necessary. I will tell you, the moment anybody mentions a required vaccine, we're going to have a battle royale. I can tell you for pediatric immunizations, when we talk about mandatory vaccines, we get all kinds of stuff. And we'll get all kinds of crap if we decide that we're going to make this a required vaccine. So I think right now that it's much too early to have this discussion. The governor said at a press conference today that Oregon has no plans to make this required vaccine. Now, I will give the counterpoint that the feds have said that employers can require it. I really don't think, it's weird because it's just weird. It's another example of kind of a muddled message that changes on a regular basis. That makes it really hard for people like me who try to explain it to others to tell, because something I'll tell you one day, I'll come back the next day and say, "Oops, we need to change that." Right? There was nothing new that changed the 1B, but yet they came out with the new 1B recommendations. It wasn't like there was anything new that came out other than a new meeting and a new recommendation. So it is really confusing and complicated. So I look back sometimes to my old things, and I have tried really, really hard not to. I've tried really, really hard not to say stuff that I have to later retract. And what I find now is that there's more and more stuff that I need to say, "Oops, I said this because," and it's because we're getting messaging which is less than clear. So someone says, "What should I do for Christmas?" So you should certainly have an incredibly peaceful time. You should celebrate the wonderful things in the world, and there are some really great things in the world. You should celebrate with the members of your household together. You should celebrate with members outside of your household, electronically or at a distance. I would be really, 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 really careful about travel. Now, Oregon had very little travel during the Thanksgiving break. Other states had a lot of travel, and they're really paying the price. So the way they do this is, I've always wondered when you're traveling along with Google and you look at the traffic overlay, and it's so accurate. It's like, there's going to be a stop a quarter mile ahead, and darn it, there's a stop a quarter mile ahead. How in the world do they know that? Do they have drones up ahead looking? And someone said, Bob, what they do is they track cell phone signals. So they're not tracking your Bob Dannenhoffer's cell phone signal, but they're tracking the overall cell phone signals on that place, which is I-5, and they're seeing how fast those cell phone signals move. And so the cell phone signals are all moving at 65 miles an hour. They plot green. If they see a bunch of those cell phone signals now stopped, then they realize there's a traffic stop, and they have this on like every little road here as to how things are moving, so they do know that kind of information. So what they did over the Thanksgiving break, they looked to see how many people traveled by how their phones moved to see. Oregon did a lot less travel than they normally did, and we had very little increase in disease. There are other states that traveled as much as they did in years past, and they've seen a huge increase in the amount of disease. So I think travel clearly associated with gatherings, which is clearly associated with more disease. So I would strongly recommend not traveling. Now, people have talked about getting a test. We did a graphic before Thanksgiving called Jane and Thanksgiving, which has gotten 10 million worldwide hits or something. And it really is pretty accurate. So Jane gets exposed on Sunday. On Tuesday, she decides, I'm going to get a test before I visit Grandma. She gets a test on Tuesday, and it's negative, as it will always be 2 days after exposure. It never turns positive on the second day. She gets a negative test on Tuesday, thinks, I'm good to travel. On Thursday, 4 days hence, 4 days after exposure, she travels and has Thanksgiving with a bunch of other families. She's still feeling fine at the time. And on Friday and Saturday, she starts to get sick and gets tested as positive. She was contagious on Thursday. So even though she had a negative test on Tuesday, she was contagious on Thursday and exposed those people. So we do not think that pre-travel testing makes very much sense, and in fact, gives people false reassurance. So the recommendations: celebrate the day, celebrate with your household. For those who are not in your household, celebrate, but celebrate at a distance. So am I doing a Facebook Live on Friday for Christmas? We were supposed to decide that earlier, and we didn't. I think we'll let you know tomorrow. We'll decide how to do this. The thing is, I don't want any of our staff to have to come in on Christmas to set this up. And when I've tried to set it up, you guys have probably noticed when I tried to set this up on my own, one time we were crooked, one time we looked at the ceiling, one time it was backwards. So I'm terrible at setting this up. We have a great team here that does this. So we'll let you know by tomorrow if we're going to do this on Christmas. All right, it's 6:54. It is time to get going. A couple of things I would suggest is for Thanksgiving, really be careful about travel, really be careful about gatherings. Again, Douglas County has done such an amazing job. When I looked and I saw we were the lowest county over 100,000 in the entire country, it was like, dang, that's pretty darn good, because we do not have any tremendous advantage. Now, there's some counties have an advantage because, like Kauai County, the only way to get there is by flying, and they can limit who comes. There's some counties that are really remote, so there's no interstates around, so people are kind of stuck in that area. I mean, we don't have either of those advantages. Some places have advantage because they have really a very young population, and with the young population, we'll have few deaths. We don't have that advantage, so we have no great advantage. In fact, you remember back in March that one of these tech sites came out and said that the 4 counties likely to have the worst time with COVID included some counties in Arizona, counties in Florida, and Douglas County. And so in March, we had this story that Douglas County was going to be like the hardest hit county in the country. And what are you doing to prepare for the apocalypse? Well, we did a bunch to prepare. And rather than being one of the worst counties in the country, we're one of the best counties in the country. And I can only ascribe that to people listening, we argue, but kind of doing what they should. I mean, I'm very impressed at how many people are wearing masks. I'm very impressed at how well businesses are doing. I'm very impressed that, in general, how kind people have done. So if we don't get together for Christmas, I would just say be safe and be kind, and we'll definitely be here next Tuesday, and we'll let you know in the press release whether we're going to do this again on Friday. Again, this is Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County. Thanks.